Good afternoon. This is Dr. Bill White again with the American Orthodontic Society. And this afternoon I want to go over a case here. It's a very interesting case. It's a Class 2 Division 2 case. That's where the upper front teeth are tucked in like this, and it's blocking your jaw from moving forward where it really would want to be. And some people have trouble with that, and some people go along with it most of their life and never realize the difference. You can't chew from side to side when your teeth locked over like this. You can't move your jaw back and forth. If you were to be able to chew properly, then somebody just put a Class 2 Division 2 on you, all of a sudden it would worry the dickens out of you. So anyway, it's something you try to get rid of for people can chew much better, and they just look much better if you open the bite where the teeth kind of overlap one another. If you want to bite a sandwich off, you move your jaw forward and bite this way, and then you go back up here and you chew it. And when you come out here and bite, your teeth shouldn't hit in the back part of the mouth. The teeth just hit right on the front, and all the weight is on the jaw joint when you bite your front teeth together like that. And this is something you need to keep in mind all the time when you're working on people. How much pressure are you putting on the jaw joints themselves? The muscle now is right back just in front of the, say, second molar, or about where the second molar is usually, and that gives you the front teeth out here takes more muscle force to bring them together than it does to bring the molars back in the back together. So you can chew something harder back in the back without hurting your muscle. You might crack your tooth, but that's a different ball game. All right, let's get back to this case. This young man has a Class 2 Division 2 with a little bit of excess vertical in the lower third of the face, and this detracts from the appearance of the case. It's hard to get it to go down. Sometimes it'll get worse as you're doing this, and so you have to really work with the case. Now, if you've got a little excess in here on a young lady, it makes a big difference. On a young man, it's not all that much of a bother. If you want to make it look better, just go ahead and smile big, and you can't detect it just looking at the person if they're smiling like that. Anyway, let's get started on this case, and I don't want to take too much of your time up this afternoon. But this is an interesting thing. I'm going to try to go along like I was just actually doing the case and kind of show you what we want to do in cases like this. Let's take a look at the young man's face first. And here is a little younger, and we haven't started the case. We haven't even thought about it. And there's not too much as far as the excess height. If this dimension and this dimension right here are not about the same, this is pretty close, and this up here. So this is pretty good. Now, as he gets a little older, this gets a little bit excess height in it. It's not really all that terrible, though, so you can do that. Here we look at it on the cephalometric. His age 12 and 2, and this is 5/12 of 88. And this is the first cephalometric picture we've taken of him, and you can see the upper anterior teeth are right along here, and the lower anterior teeth are way up in here. So he's got a closed bite. The laterals aren't sticking out like a lot of times on Class 2 Division 2 like this, but they're really close. Now, this keeps him from bringing his jaw forward. Now he might really like to have his jaw closed and chew further. The head of the condyle may be bothering some by being too far back and being pressed into this retrodiscal tissue back here in the back of the mouth. And if it is, it'll bother you. Every case you work with, I don't care if you're just doing any kind of dental work or whatever, you ought to examine the jaw joint. You can get behind the patient and put your fingers on just in front of the earlobe right here and kind of move your jaw from side to side, and you can feel, you can right now, if you want to sit down and just put your fingers back there. Now wiggle your jaw from side to side, and you can feel that kind of round effect of the person there. You can open, or you can kind of take your finger and go around the head of the condyle back here at the back of the mouth. I've gotten throat stopped up already. So if you put pressure on this at all, and you've got a sore place, if the condyle is too far back and it's pressing this retrodiscal tissue, and I know you get tired of hearing that word, but that's where the synovial fluid is made, and that's what feeds the disc. It's between the condyle and the fossa up here. It's a kind of a double concave device in there that kind of, as you open, well, if you made it like this, as you open the mouth, like this, the disc kind of follows the head of the condyle, and it has attachments, and there's a upper and lower joint space in there. You ought to examine everybody, and if they got any problem with that at all, in other words, they may be clicking, they'll open, they'll go, their jaw will go to one side, and then they'll pop, they'll straighten out, and it may pop the same time on both sides. Both of them can pop at the same time. If you get the pop, normally it can happen from some rough in there, but nearly all the pops, the disc is tied on with a muscle attachment, a ligament to it, and as you open the mouth and the condyle is moving out like this, and this ligament gets tighter and tighter, it'll pop off, and the disc will actually go in front of the condyle. Now that sounds funny, but it'll get out in front of the condyle, and so you can write that down on every case you work on, so that if something you do causes this to happen, you remind people that you've got the disc is off and you've got a click in here, and if this is sore, you better figure out what's caused it to be sore and try to advance the mandible and free it up. All right, that's enough on that for a while. There's a lot more to that, so get over with some of the videos showing that more. Now we are going to go ahead from this point right here, and this is the models. You just take somebody's models. They can just hand you a set of models, and you put them together the way they chew. And you can see that these upper teeth, you see, are just too far down, really, and it's not so much the upper teeth. The lower teeth, you come along here, and then the lower teeth are way up here, like that. So we're starting off with a lot of curvus via in here, and we're going to try to lower these lower teeth down, bring them down. And this bringing the teeth down that way allows them to be freer, and they can move forward. And the motion that you put on, the force you put on them to take them down, like if your lower anterior teeth are kind of leaning back a little like this, and you put pressure on that going down, the root on this tooth is going to move the tooth out this way, see. So as this goes down, it will move forward. But as it goes down, there'll be more room, and we'll start pushing these teeth up a little bit in here. And you can watch that take place. And he's got his cuspids locked out over here. We've got a lot of problems in that respect. Now, if a class 1 case, the upper molar has to be out in front, the lower molar will have to be out. In other words, this will be kind of like this with the molar when you're fitting in there right. This cusp will go right out of this part, and this will come right in here. In other words, this lower jaw is back at least 2-3 centimeters like that. Now, if you raise these teeth up, they will tend to move forward as you go up because the roots are going like this, and you're going up. This tooth will move out, and you're going to need some space in here because of the cuspid. So you let this go ahead and happen. Just raise it on up, and these teeth will move out in this direction as they go up a little bit. And that frees the bottom up, and you go down with them, and they come forward like this. You can just look at the model and tell you a lot of things that happen in here. This young man is probably somewhat of a mouth breather. He's got his lower jaw. It's not a terrific mouth breather, but the upper jaw is way too narrow and way crowded, and he's got plenty of room for these teeth, as you will see as we go on through the case. All right, let's look on the other side. We've got a cuspid tooth coming in over the lateral right here. This is the first bi, and looks like the second bicuspid coming in here. So we're going to have to open up a space in this area and bring these teeth. As these teeth move further out, we're going to use that to bring this cuspid down into this spot right here. Excuse me. Now the lower teeth are up way in the top of the mouth and they're almost touching right up here like this. So as we come down with this, you see how the lower teeth have worn the side of that tooth off and here, trying to true from side to side even at his young age. Now we've got to put the cuspid in here and a cuspid in here, space here for this to line up, and these are going to have to straighten out and coming up this way. We use these little tiny brackets that just sit on there. We have used them so much we know how to position them on the teeth and how to rotate teeth with those if you like it. Now you ought to etch and wash and dry and put sealant all over the area of the tooth you're going to have brackets on. If they brush it off, well then they'll be brushing the tooth so it doesn't get decalcification. If they don't brush an area, it's covered with a sealant and it'll stay on for a long time, and usually you won't get the decalcification, and that's something you really don't want to have. Now let's look at the lower arch. The cuspid over here is really crowded out, and these teeth are all around to one side. You see this lateral here, and this is the lateral over here. Now as we bring this down, we're going to have to kind of widen this out, and we'll bring these cuspids back, and you can expand cuspids on the lower arch all you want to. If you'll just take the root of the tooth and go back. Now what they did, this is my own thinking, that it came out you can't expand lower cuspids, and you can expand lower cuspids and you can get them to stay. I did a woman 10 years and it was still there, and I carried her 10 more years and it was still there, and I'll bet you they bury her with her teeth there. See, now if he told the people to expand in the class, they were in a big hurry and they just kind of did them like this. and then the cuspid over here, they kind of spread them like that. Now the cuspid's going to come back, but if you take the root and go back with the cuspid, then the cuspid has no sacred position up there. It's going to find it'll stay there unless there's some other reason for it to come forward like that. So down on this area, we're going to have to expand these teeth, and the cuspids are going to have to be tilted to the forward position, which we will show you. It doesn't have to be much, but you don't spread your cuspids this way. You spread them by bringing the roots back along with the crowns. Whenever you do that, it'll take you a little longer to do it. All right, here, now we're going into the mouth. This is 5 of 88, and you can see this cuspid trying to come down in here. This lateral's turned sideways. It's got a little problem there. The cuspid is over this area trying to get in there. So we got problems, and the teeth are right in the middle. This midline needs to move back. See, these teeth on the bottom are always way back over to the left. All right, let's get on pretty quick here, and we'll try to show them the right side. You can see where this cuspid would come down through this area right there. And the bite's closed, so we're going to raise these teeth up a little, and we're going to depress the lower anterior teeth. They go down. As the teeth go down, they carry their bone structure with them. You don't shorten the tooth. Now, if you take one tooth and then push it down and leave the others, you can push the root of the tooth down into the bone to some extent. Pardon me again. Okay, let's get on from here. And here we're looking at the other, that's the left side of the mouth, and it's class 2, division 2, and those teeth are covered up. Here are these upper anterior teeth, looking at them. We're going to have to advance these, and this will all be out and something like that when we get through with this. And you can expand the upper arch and bring the teeth forward, and it'll look good. Now this is a class 2, division 2 type situation. Now when we get down onto the lower arch, we've got a baby tooth sitting in here, and that baby tooth is the last molar on the baby arch. You can shave off and do a pulpotomy on this tooth right here and save enough room here for the bicuspid and move this bicuspid back. It'll go back when you trim this back and do this pulpotomy, and then you take that tooth out, and this tooth has room to come in, and this one is fitting up here, and that gives you more room in this area for the cuspids. So a lot of people are afraid to do these pulpotomies. We've got video after video of doing pulpotomies, and I bet I've done thousands of those things, and I've never had one go bad. And you do not put a rubber dam on them. You go cut this tooth. In other words, this tooth will be setting something like that, and the roots of those baby teeth kind of come out like this, you know. And you take this tooth down like that, and then you just go in and kind of run down the horn of this right here, and you fill this with zinc oxide and eugenol. You have to pack it in there, and if you pack it in there, take that out. Do not blow air in there, just aspirate it, and you don't care if it's bleeding all over the place. Just pack it with this heavy zinc oxide and eugenol, and it'll stop the bleeding, and it'll go down in the tips of these roots. And I know way over 1,000, and I've never had one of them blow up. Now, an old surgeon did one for somebody, and it blew up, and somebody in a lecture in Atlanta saw it and jumped up and down, you know, that I didn't know what was going on there. And so, anyway, there's things I don't know about, but I do know a lot about doing pulpotomies on healthy deciduous teeth. I've done so many of them. It'd be amazing. Now, we'll see what happens in here. All right, we gone in here and we've leveled out, and now we're coming down with these teeth. This is an intruding arch. It comes out of this deal over here, and it has a little deal, and it runs down this way, and you raise it up and hook it in, and it's pushing down on these anterior teeth, and we're opening a space over here. As you go down, it'll open the space anyway. So we put the spring in here, and we'll have room for those teeth. And we're going to center these teeth up in the midline right there. Now, this young man is not brushing his teeth properly. And so you need to keep an eye on that. But we've got sealant on them, and so where he doesn't brush, the sealant stays. If he brushes it, the sealant goes away or wears it out, but he keeps it clean brushing it. So sealant is something you really want to use if you're not using the stuff now. Now, this is 10 of 88. Now we're opening this gap. We've got a little flexible wire in here with this loop. Probably went up like this, and we backed it up so it's pushing on this, and we put a spring in here, and so the gain you gain in arch length will be right in this area here. And so we'll get that cuspid to come in, and that will also bring it over, and we're going to have to pull this back in that direction to line it up. We open the space on the bottom arch. As it goes down, the intruding wire helps make the space also. Now, as we're getting this down, this lateral position is pretty good. It's coming out. We're going to bring this cuspid down into this spot right in here. We need a little bit more space over here. This cuspid is in good now, and we've got some to spare, so we're going to move this around a little bit and bring that up in this area. And we'll center. You can look down here. It doesn't need to go much over there to line that up. These teeth right here need to have a little more curvature in here to level them out. All right, on the bottom, we're intruding them with this heavy wire. This little flexible wire now is doing all this other stuff. So we're going to shorten this off and make room for this bicuspid to come back here, and we'll have enough room, and also we'll move these molars forward a little bit and take up some of that space and put them into class 1 relationship. And now the teeth down here, as we get the room, we're going to bring them out. So let's just look at the guy. You've got a teeny little bit excess vertical height of the face, you see, in there. So that's not bad. This is not going to hurt a nice looking kid. Got dark blue eyes, and here now at this point we've got the midline almost lined up ideal. We're using the class 2 elastics on here to pull these teeth forward a little and bring this back, and he really needs to get in there with his brush. That's gum swollen up all around here, and that's, I tell you, don't just talk to the boy about brushing his teeth. You talk to his mother, and if he's still messed up with his mother, call his father in with him next time. Father and mother. I have gone through cases where a young man just would not. He was a good kid, real nice, do everything else, but just wouldn't brush his blooming teeth. And I talked to his mother and talked to her and tried to get it. Finally, we just had to give up and quit the case and take it off. And he had a bunch of cavities that he had to fill where it was nothing but decalcification. That was before we had this sealant, good sealants and everything. And his father came in and he started paying for all these fillings. I didn't do them, his dentist was doing them. And he was really hacked off at me. He says, "You should have told." Well, I told him. I did everything except hit him over the head with something to get him to brush his teeth. From after that, when I told the boy and he didn't do it, I tell the mother and the boy, and if they still don't do it, have the father and the mother, and if necessary, get his grandfather back and have brush the teeth. So you get out from under it. It's their duty to do it. But if you use sealant now, we just cover the whole tooth with etch it, cover it, and if there's a place that he's not brushing, the sealant wears. It'll stay there for a long time, and it covers that tooth up. So anyway, using good sealant, and then tell somebody's going to have some influence on this young man. All right, here again, not brushing as good as he could, but we go on, and I'm going to finish this up real quick like now. Here we've got the laterals in. This one has a little more torque, you see, the tooth sticking out here further, and that's one we had to bring through last, and it needs to be torqued and bring the root of that tooth further forward right there. Everything else looking pretty doggone good. On the bottom, same thing, everything. The torque is good down here, and the second molar are coming in later here. I see we've got a bracket on that one. I can't tell here whether this was got a bracket or not. But here we are. This is age 13 when he came in, and he was 13 years of age, and he had wisdom tooth here, one here, none here, and one down here. And his jaw is too short for those wisdom teeth. So we had to expand this out and put all those teeth in there. But you leave a wisdom tooth in there that's growing in this direction, and you put this tooth up here and leave it, this wisdom tooth will push on that, and it'll push on this, and did my own son didn't go in and get his brothers to do his wisdom teeth, and on one side, well, they took them out on one side, but they didn't on the other, and that's the side that crowded up. So if somebody tells you wisdom tooth can't move these teeth up here, that's crazy. They can move it. Now you watch this tooth right here. You see this distal root. When you see this tooth is developing its root too far down here, you ought to go in here and take that tooth out. Make sure you get that root out of the way, and then this tooth will come in where you take off the baby tooth, and it'll come in here, and then you expand this. Now we've got a class 1 molar relation. When this tooth moves up into this area a little bit, you still got room for a bicuspid. So you've got room for this to come forward. Now he's age 12. Let's go to another Panorex. This is Panorex. Now this Panorex, we were pressing down on it. So this wire was like this. We pulled it up. It's pushing these teeth down, and that's going to push these teeth up, and they tilt the tooth distal. The chewing, he wasn't chewing hard enough on them, but see where those two teeth went back this way, but these teeth went down, and that will crowd this up, and you got to do something with that. So don't get excited about this being out of place. When you take that off, this is going to straighten out on its own virtue. So we have to go back and have his wisdom teeth removed in a case like this. All right, there, that just shows it again. There, those teeth are tilted. Now we've got them back, and he's still haven't taken the wisdom teeth out. So don't take this off until you have eliminated this. If this is allowed to stay there, it will put force on all these teeth, and you'll crowd them up. And that's my own son, the youngest boy we had of 4, but his teeth are crowded on one side because his brothers didn't get his wisdom teeth out over there. But you see how that's straightened back up. Now let's see, I hope I've got another, but I don't. So this is the way the teeth we started, and there it is now, and this midline is dead center right there. And we got through with the sealant and everything. We don't have any decalcification up here, thank goodness, but he's still not brushing his teeth properly. So you got to really stay on it. I like to see this person 10, 15, 20 years after you finish this, you should see this stay almost like this. Now we make a retainer, it goes in there, and on these deep bites we put a bite plate on it, and if they wear that retainer, it will not deepen, it stays. But if they leave it out, it can deepen some. They put it in, then when they bite to it, hits where the retainer, the bite plate is, and these teeth don't touch. And now when you bite on this, the force is back here on the condyles, and the person will come in with their jaw hurting because they left the blooming retainer out of the mouth and their bite closed down again. And so then you got a problem he's got to wear it to get it back in place. You may have to put a little block back in here to relieve the condyle back here, and then whittle this down slowly, and then these other teeth can come in place, and when they get in place, you can take your block off there. So that's retention of these deep bite cases. Now there is the starting point, and there we are at the end. He's not biting all the way to, but these teeth are free to run into each other. Don't put any kind of clasp over these through here. If you just build your retainer and put it in there, seal it good up there, this will stay in place. If you have a problem with it coming out, put the retainer wire in there and put a tiny bit of composite under, say, the cuspids if you want to, or the first bite, and that wire snaps over that, and that'll keep it there with no problem at all. So hope you get something out of this, but this is just kind of the way you would think and do in doing a case like this. Now, if you think, well, what's the difference? Well, why go in and straighten somebody's teeth? Can you imagine what this would look like when this guy gets 21 or 30 or 40 or 50 or 60, if he's still got them? I mean, if they can come in and you know how to do that, it's a shame that we are not teaching some orthodontics to dentists in general. They ought to know what's going to happen if they don't go in and do something, or if they don't want to do it, let somebody else do it. If they want to do it themselves, then learn how to do it. We teach them that. Just learn orthodontics. And this old nonsense of not showing the general dentist or anybody else what ought to be done in the mouth. The people do some of the dumbest things by not knowing orthodontics or something in orthodontics. Get off the pulpit of preaching to people probably that are real caring about this. But anyway, that's the way you bring somebody around, you put them in a retainer, and you have them stay with that. Now that's the upper arch, and this guy, there it is after we straightened it up. It's much bigger, much better room in there, and so you've got to wear this retainer till the thing settles in at that point. Down on the bottom, same blooming thing. We did the reduction of that, or else we just took that tooth out. Now here's this 3-to-3, which I think is a very good thing to put in, and I actually bond them to each of these teeth. And if you don't wear the retainer, at least those teeth will stay fairly straight. But you've got to run something underneath there with your dental floss to take care of when you bond on top of this like that. So I hope that everybody who sees this, wherever it is, I know this has been a godsend, this YouTube stuff. I mean, I've gone over these cases with people for 20 and 30 and 40 years and showing people, and just a handful of them learn it, and there's fewer than that actually do it. But now, wherever you are, you can take one of these videos and darn near learn what to do with that. But this is what you do. But check everybody's jaw joint and make sure it's working right. If it's not, it'll be sore, or it'll make noise, or you'll open it, it'll go and like that. Sometimes it'll be on one side, and they'll go and it'll pop back in place like that. And you will know exactly what's happening up here. And you can't get rid of the clicks, but you can get rid of the pain. And of all the people that I've seen in 30 years of TMJ problems, we got rid of the pain in every one of them. And if there's somebody out there that had it and we didn't get rid of your pain, give me a call or get in here. I do not remember a single person we left in pain there doing that. So I'm going to hang it up, and thank you for watching. And I want you to join our group and subscribe to this.